So welcome back, everybody. Back to your validation day as promised. And again, I'm the diabetes program lead. My name's Mary Ann Strobo, if you're trying to look for me in the global address book. And as promised, I wanted to go over a little bit about our hypoglycemia orders. If you remember when I met with you initially, I told you that our hypoglycemia orders are very wordy. There's an awful lot to the order set. And you do have to know everything that is in the orders. I'm not going to go over each one individually, but I just wanted to give you a quick overview of what they are like here. So as you can see, there is different treatment that you would have to do depending upon if it was the initial blood glucose that you took, or if it was the recheck, or if it was the third time that you were rechecking the blood sugar. It also has different orders depending upon what that blood glucose value initially is. So if your blood glucose is less than 40, you would not only notify the provider, but you would also send a glucose serum stat to the lab. And then, of course, the other thing I wanted to point out with the hypoglycemia is please be careful to note that you're going to recheck that blood glucose every 20 minutes until that glucose value is greater than 100. So just because you're going to recheck it in 20 minutes from the first check, you may get a value that's something less than 100. That means you do have to go back and recheck it again. So you would do that every 20 minutes until the glucose is greater than 100. So please take the time to look through those hypoglycemia orders and make sure that you're fully aware of all the differences between whether or not it was the initial blood glucose or was the recheck and what that initial value was. And if you have any questions, remember you can always reach out to me. If you are here during the daytime, and you can always call me, and my phone number is 77337. You will get to my office phone. And I am, of course, on Vocera. If you want to email me, again, my last name is Strobel. That's Strobel. And I am in the global address book. So how often do you want to check that blood sugar? So you want to check it before meals, within 15 minutes. Now I know real life does happen, so try to get that somewhere close to that 15 minutes before the meal. What I don't want you to do is I don't want you using a blood glucose value that's greater than an hour old in order to make a dose decision. As you know, our glucose levels, they fluctuate many times throughout the day, and sometimes you can have a large fluctuation even in a short amount of time. And so you're really setting yourself up for a possible problem if you're going to use a blood glucose that's greater than 1 hour old in order to make a dosing decision. So please, keep that in mind and recheck that blood sugar if that blood glucose value is more than 1 hour old. When should you be giving that insulin? Well, our Lispro insulin, which is the insulin we use most of the time in order to give a scheduled dose before a meal. We'd like to give that up to 10 minutes before a meal or immediately after the meal if you're uncertain of that oral intake. You do need to know your insulin duration times, and if you recall when I met with you earlier, I did show you the different insulins that were on our formulary, and I did ask you to please go through them and try to know what is the onset, the peak, and the duration times. We do have a chart. I'm going to go through this quickly here, see if I can find that chart where we have our formulary insulins. So bear with me for a moment here. There it is. And so as you can see, the insulins that are highlighted here in yellow are the insulins that you will see most of the time. They are on our formulary. And as you can see, I do have here on this chart the onset, the peak, and the duration, as well as the administration time. So again, this is really important. And as I had stressed to you earlier, the reason you want to know this is because when you know that insulin is going to start to work, that's a time that you should start to see a change in the glucose value, whether or not it's going to be bringing it down within a more normal range, or it could have the ability to bring your patient down too low, and your patient could be suffering a hypoglycemic event. Additionally, during that peak time, that's when your insulin is going to work at its strongest. Your duration is important because if you're giving insulin dosages too close together, especially with your Lispro, something happens that we call stacking, and again, that can put your patient at risk for hypoglycemic event. If you would like to have a copy of this, you can email me, and I will be happy to email you a copy of this chart. So let's go forward here and look a little bit more at what I have to offer you today. So these are the parameters for a diabetes consult. You can consult me. Just remember that I am a scarce resource. And so I am going to be seeing your patients that are very, very complex. Of course, I'll be seeing your insulin pump patients as long as it's not on a weekend or a time when I'm not here. I will be coming by, and when you put in the insulin pump order set, I will automatically be consulted via that order set. If you have any other questions about patients that you want to refer to me, one of the best ways to use me, of course, is to call me or email me and ask me questions. If you want me to look at a patient's chart and you do want to email me, I do want to caution you not to put the patient's name in the subject line of the email. Please put in star secure mail star in the subject line of the email, and any other information regarding the patient, such as their MRN number and your concern that you want me to look at, would go in the body of that email. Of course, the best way, again, to reach me during the daytime is on the Vocera. Just call my name and I'll be there for you. So all of these things that I'm going quickly through over here, again, are going to be in your orders. So you'll see these things on your MAR, or you'll see them in your orders under nursing. So what I want to show you again over here is this glucose screen. This is another really important thing to use. As I told you earlier, this is going to save you time. This is my gift to you. This is your gift of time. And when you analyze your patient's blood sugars by looking at the glucose screen in Epic, you are going to be able to hover over different areas within this chart here. For example, if you hover over a red dot, it will tell you that point of care glucose finger stick. It'll tell you the value, it'll tell you who did it and what time it was done. Of course, if you hover over the blue dots, it's going to tell you what the lab draw glucose levels were. And on this, you will also find your different insulins, their dosages, the time it was given. If your patient had received any steroids or oral agents, it'll also be on there. And as you can see from this example right here, you can actually look at the trend. Now, the trend is important because if you start to see your patients going in a downward trend, you know that they're going to eventually be at risk for a hypoglycemic event. So that's your opportunity to talk with the prescribers and see if there's any dosing changes to be made. You can also look and see if maybe dosages were given too close together. And you can also, see if your patient is trending upwards, if maybe it's time to contact the provider as well and ask about any dose adjustments to counteract any hyperglycemia. So please, if you don't already have this glucose screen, go to your summary page. Go to your wrench. So please, if you don't already have this glucose screen, go to your summary page, go to your wrench, which will be on the right-hand side, and do wrench it in under the word glucose. And if you'll just want to read this here, this is just be aware and prepared for hypoglycemia. As I said before, have conversations with this prescriber. If the blood glucose is greater than 180 for more than 24 hours and there has been no dose adjustments. And remember, again, to be aware of that timing of your point of care, finger sticks, and the insulin administration times. That's very, very important. If I leave a recommendation for you, you will often find it under the sticky notes. So please do read the sticky notes. They are important. If I have called you on the phone, remember, if I call you or if I come to see you, I'm never calling to complain. I'm calling because I've seen something that you may not be aware of. But if you and I have discussion, I will be putting a note in that we did discuss it. And if you've agreed to something, I will put that in my note as well. So please keep that in mind. Of course, it goes both ways. If I've said that I'm going to do something, I do expect that you will document that as well, and I will follow up. So as far as insulin pumps are concerned, what I just wanted to say about that today is that insulin pumps are patient-owned. They are very, very expensive, so we treat them as a valuable. And that the physician or the prescriber has to be the one to determine whether or not that patient is cognizant, capable, and able to continue using that insulin pump in the hospital. That decision is not up to the nurses. I do caution nurses, though, to have a conversation with the prescriber, especially if that patient is coming in and they have a very high A1C. What that tells me is that either the patient is not that capable of knowing how to utilize all the features on their insulin pump to maintain good glycemic control, or if whether or not that insulin pump is actually programmed correctly by the outpatient prescriber in order to meet the glycemic needs of the patient. And patients sometimes are not able to follow up with their outpatient physicians quickly enough in order to make those necessary changes that should happen about every 3 to 6 months. And so sometimes we do find that that is also an issue. So if you have any questions about patients with insulin pumps, number one, you can always contact me. And number two, remember, you have diabetes resource clinicians on all of the units. Reach out to one of them. They're very knowledgeable in how our insulin pump policy works and all the pieces that are part of it, as well as you can talk with your managers. Your managers have a list of the diabetes resource clinicians that are across the entire hospital, and therefore if you don't have one who's working on your unit that day, that doesn't mean that you won't be able to reach out and get information from another DRC on one of the other nursing units. So that is a good recommendation for you to keep in mind. One thing with the insulin pumps, I just want to make note, is that patients will need to continue to have their blood glucose checked on our glucometers. So even if the patient has a secondary part to their pump that's called a sensor, that doesn't allow the patient not to have their blood glucose checked on our glucometers. So that is something the patient has to be agreeable to in order to be able to continue to use their insulin pump within our hospital. Sometimes that's a point that you need to somehow discuss with the provider who is going to be ordering the patient to stay on their insulin pump and remind them that that is our policy. If you are looking for your diabetes resources, which are going to be your diabetes educational booklets, oftentimes diabetes resources, which are going to be your diabetes to do diabetes education, because as you know, here at Houston Methodist for the we are all responsible to do diabetes education, because as you know, here at Houston and if you are looking for those booklets, because I've put an order in, you do go to the internet page for those booklets. You will go under nursing, which you can see there. You go to the left-hand side. You will click on that. You will go under nursing, and it will take you to our internet side nursing page. You will click on that, and over there on the right-hand side, it'll be diabetes education page. Click on that, and over there on the right-hand side, it'll be diabetes education, where you will find that. It will take you on the left-hand side. Click on patient care, where you will find, and then you will find all the resources that you need. Both of those booklets are available in English and then you will find all the resources. If you are looking for booklets for pregnant patients, they're also available on this website. If you are looking as well as a pregnant patients, they're also available for the insulin on this website, as well as a link to our policies for the insulin. Here's an example of what the booklet looks like. And don't forget to chart the diabetes education that you do provide. So now what I'd like to move on to is the case studies that I'm going to have you do today, which is going to be your little interactive exercise. We do have about 5 or 6 cases, and I'm going to go get those ready right now. So stay tuned. So everybody, now what I'd like to do is have some interaction here, even though we are doing this by technology. And what we're going to do is I'm going to have you choose one of these case studies and look at it, and then using some of the resources that you will be able to click on, and would like you to look at the case study and come up with some solutions to how you would care for this patient. So let's look at case study number 1 and take some time and get that done. And then after you're finished and you have some of your answers, I'll go over it with you. I will read it for you first here, and then we will review it after you've done everything on your end. So case study number 1 is Mrs. Davis is a 78-year-old female She has type 2 diabetes for about 26 years. She was admitted for chest pain. Her A1C is 11.2, and her inpatient meds includes glargine insulin at 45 units at night and Lispro 20 units at each meal, along with a median correctional scale. She has a healthy heart diet ordered, and documentation shows that she's been eating about 75% of her noontime meals. And you can see the pictures below of what she's been eating. But after she's been eating this noontime meal, she's been experiencing hypoglycemia at about 2 o'clock in the afternoon for the past 3 days. So what I want you to think about is, what are some of the possible explanations for her recurrent hypoglycemia? So have a look at these foods here. I'm going to explain them to you in case you don't see them too clearly. The first meal over here that she's been choosing from happens to be some fish, some salmon. It's baked. Doesn't have any breading on it. It has some asparagus and some salad. Looks like a piece of lemon, a little bit of cottage cheese, and a Diet Coke. Her next meal that she's been choosing has been a little bit of beef with some mushrooms, a small portion of what looks like maybe a mashed potato and some broccoli, as well as a roll and a glass of water. Her third choice over here that she's been having has been a grilled chicken salad with olive oil vinaigrette, along with an unsweetened iced tea and a small fruit cup. So take some time, look at your resources, and try to tell me what is the possible explanation for her recurrent hypoglycemia at 2 p.m. every day after lunch. Okay, take some time and then we'll come back and we'll look at the answers. So welcome back, everybody. I hope that you have some good answers there together. So what I want to do is I want to go over what I've identified, and let's see how close that you got with it. Let me put my glasses on here so that I can see. So here's some of the answers. So what are the possible explanations for her recurrent hypoglycemia? Well, if you looked at the foods that we talked about earlier, there's not a whole lot of carbohydrates contained in any of these foods. The choices that she's been having have been over here with this one with the fish, the fish, the salad, the asparagus, and of course the Diet Coke shouldn't have much impact at all on her blood sugar. A little bit of impact from the cottage cheese. So really not quite enough carbohydrates in that meal. The other meal that she's been ordering has been the piece of beef with the mushrooms, then the broccoli. That won't have any impact. She does have a little bit of mashed potatoes and a roll. That'll have a slight impact on her blood glucose, but again, may not be quite enough carbohydrates. The grilled chicken salad, again, there's really nothing in there that's going to spike her blood glucose. Unsweetened iced tea won't do anything. The fruit cup is only going to give her about 15 grams of carbohydrates. So part of her problem has been that she hasn't been ordering enough carbohydrates at lunch. One of the things that you can do is, of course, try to help her make better selections. You can go in to her room, tell her to call you whenever she's ready to order, and maybe you can look through that with her, or you can call the concierge to talk with her, either in person or by phone. And the dietitian and concierge will be able to help the patient make some better choices for her meals. The other thing is, you want to make sure when you're checking that blood glucose prior to her getting her lunchtime, as well as all of her meals. Remember, if they're more than 1 hour old, that you don't want to be using a 1 hour, greater than 1 hour old blood glucose in order to make a dose decision, because you could end up making the wrong decision, especially on that medium correctional scale. And again, if you think that 20 units of Lispro before each meal is too much, have conversation with the physician, especially if you're seeing this recurring every day, then that becomes a pattern. And then do look to see if she's having any issues with her kidneys. Now, it's not listed on here, but we do know that when patients are having issues with their kidneys, since insulin is renally cleared, that they can have a potential for stacking. So again, make sure that she's ordering these meals, that they are at least 4 to 5 hours apart. So if you've gotten some of those answers, then you've done a really good job on case study number 1. Let's move on to case study number 2. So case study number 2 is Mr. Jones is a 66-year-old male with type 1 diabetes. He's had it for 18 years. He was admitted for a lower leg abscess. He has cellulitis and hyponatremia. His A1C is 8.2%. He's on an insulin pump with U500 regular insulin at home. And let me tell you a little bit about that before we go any further. So the regular insulin that we normally hear about is a U100. What that means is there's 100 units of insulin in every milliliter. When you have a U500 regular insulin, that means there's 5 times the concentration. It's very concentrated insulin. So that means that this patient has a high degree of insulin resistance in order to have his doctor have put him on U500 insulin. So the doctor has approved him to continue using the pump therapy in the hospital. He's been getting 3 intermittent IV antibiotics to treat that infection, and he's had multiple episodes of watery diarrhea in the last 12 hours. He was made NPO on midnight for his IND abscess in the morning. And so the night RN told the patient to stop their insulin pump infusion at midnight because of being NPO. You come on at 7 a.m. to take over his care. Do you have any concerns for this patient? You should. So why don't you think about that, and we'll get back together in a few minutes and see what answers you've come up with. So welcome back, everybody. I hope that you've come up with some good answers. Here's the answers as I've seen them, thinking about this patient. So we know this patient has the U500 concentrated insulin, which, as I gave you that hint before, it is 5 times the concentration of U100 regular insulin, which we know that this patient is getting a lot of insulin. Now, the nurse was trying to help and told the patient, to stop that insulin pump infusion at midnight in anticipation of the surgery the next day. However, we as nurses do not make a determination to stop any medication without getting an order from the physician. So there was no order to stop the insulin pump or to adjust the basal rates while NPO, although it could have been possible, but that again would have been the nurse calling the physician, and none of that information was available on this case study. So if you are ever unsure if a patient should continue to use their insulin pump, if the patient should continue to take an insulin dosage, your job as a nurse is to contact that provider. Remember that patients who are on an insulin pump are on an insulin pump because they have a relative or an absolute insulin deficiency. Without that constant insulin infusion, these patients are at great risk for going into DKA, and we don't want that to happen. So you don't stop insulin or don't give an insulin dose unless you have orders, and or if you are concerned, you call that prescriber. Type 1 diabetes, even though NPO, again, cannot be completely without insulin coverage, oftentimes we refer to patients as type 1 as having absolute insulin deficiency. If you're going to take a patient off their insulin pump, per our policy, it says you must contact the prescriber in order to get an alternate form of insulin coverage. And then, of course, if you have your patient with recurrent diarrhea or vomiting, of course, it can cause an electrolyte imbalance. It's another reason to contact the provider. So if you've had any of these answers, then you did a great job. So congratulations. Move on to case number 3. Case number 3 is, on Saturday morning, you assume care for Mr. Anderson. He's a 47-year-old male. He's had type 2 diabetes for 8 years. He was admitted the previous afternoon for symptomatic hyperglycemia that he's had for about 2 weeks. His admitting blood glucose was 542. His A1C, 13.4%. At home, his diabetes meds are metformin, 1,000 milligrams BID, glipizide, 5 milligrams BID. And of course, the patient says he was really surprised about that high A1C because he's been really diligent with taking all of his meds as prescribed. So here in the hospital, the physician put him on basal bolus insulin, which we know to be long-acting insulin, like glargine, in addition to Lispro, given pre-meal and or by correctional dosages. And his blood glucose now is running between 140 to 180, which, as you know, is acceptable range here in the hospital. He's also anticipated to be discharged to home late Sunday. So you are the nurse working that weekend, and in anticipation of Mr. Anderson's discharge, what do you need to consider? and or do regarding his diabetes so that he is ready to go home. I want you to come up with some ideas for his discharge plan. Take a few minutes, use your resources, and get your thinking caps on. These answers for case study number 3. So, given that high A1C that we had with this patient, and if I look back here, I see that his A1C, just to refresh us, was 13.4%. What do you think he'll be going home on? Do you think this patient might be going home on the metformin and glipizide again, or do you think that maybe since the insulin works so well here in the hospital, more than likely the physician is going to order insulin for at home? Most of the times you see the physician will order insulin for at home. Therefore, this patient's going to need some teaching. It doesn't show in this case study that this patient has taken insulin before. So you as the bedside nurse have a perfect opportunity to begin that insulin instruction. So when you go into the patient's room for the patient to have their insulin dosages, ask the patient if they would like to self-inject. You can do that. That is part of what you can do. Moreover, you can do that. That is part of what you can do. Moreover, if you recall, all this whole incident was happening on the weekend. And as you know, I'm not here, and so I wouldn't be able to come and help you with that. So that's something that you should be thinking about and giving that patient as many opportunities as possible to do that self-injecting. Remember that when the patient goes home, he's going to need to be able to check his blood sugars in order to be able to take the correct insulin dosages. So you need to talk with the patient and ask, do they have a working glucose meter and supplies at home? And if they don't, do discuss that with your prescriber at discharge so that a prescription can be given to the patient. And talk to the doctor before the patient is ready to get out the door. If the patient doesn't have insurance, you can talk with your social workers and your case managers to find out if the patient has insurance. And if the patient doesn't have it, then you might have to have more conversation with the physician about what the patient can afford in regards to types of medication once they go home. As you know, some of the insulins are very, very expensive, and they can be well over $600 a month to sustain both a basal and a bolus, a long-acting and a short-acting insulins. And so again, get your social workers and your case managers involved as soon as possible, because as it says here, discharge planning is everyone's responsibility. So thank you so much for taking this lesson on glycemic management for your validation day. Remember, we have your diabetes resource clinicians on every unit, and you need to find out who they are. If your diabetes resource clinicians are not working that day, remember there are other ones within the house that you can reach out to your manager. They will be able to find out who the other people are on the other floors. They are available for asking them questions about where to find resources and giving you some other information on knowledge about our policies and procedures relating to glycemic control. If it's during the time that I am here, I would love for you to reach out to me. That's a great way to use me. Again, my phone number for my office is 77337. I am available on Vocera, and you can always email me as well. Thank you so much, and I wish you all a healthy day.